Hello and welcome to Health Matters on Channels Television. I'm so glad that you're here with us. I am Mary Alale Yusuf. The global figure for COVID-19 as at October the 2nd was over 34.6 million. More than 24 million people had recovered, and there were more than 1 million deaths at almost 20 million cases. The US, India, Brazil, and Russia have more than 57% of the global COVID-19 burden. That's it there. On the same day in Nigeria, 59,127 infections were recorded cumulatively, out of which 50,593 have recovered and 1,112 have died. That's no deaths in 3 days, people. No deaths in 3 days. The overall recovery rate is about 85.6%. Mortality rate is still about 1.9%. So far, 520,797 samples have been tested. That's just over 26,000 samples since the previous week. And just from the previous day, over 11,000 samples. We're getting better. Primary health care is a term used to describe the first contact a person has with the health system when they have a health problem or an issue that is not an emergency. We want to find out what the role of the primary health care is in infectious disease prevention. My guest is a consultant public health physician from the University of Lagos, a member of the Association of Public Health Physicians of Nigeria, and the Association of Medical Officers of Health in Lagos. Dr. Shalom Uni.
Thank you very much.
You're welcome to the show.
Thank you very much. I'm glad to be here.
Okay, so people have the impression that the professionals in the primary healthcare sector are somehow not as qualified as the ones in secondary healthcare, teaching hospitals and all that. And, who are the staff we should actually expect to see in a primary healthcare center?
Thank you very much for that question. Well, that perception is not true because...
Well, you have noticed it, haven't you?
I have, really. It's there. But it's not true because the health workers that are at the primary health care and in our primary health care centers, they are highly cerebral. Many of them schooled. Now, let me start with the doctors. We have a lot of doctors at the primary health care level who have postgraduate, some of them postgraduate studies, the master's program, some of them diplomas. Some of them are even begun, residency program, some clinical level of clinical attachment. So at the doctor's level, we have quality healthcare professionals. Going back to the nurses, there are some nurses at the primary care who do not only have certificates in midwifery or basic nursing care, but they also have certificates in community health, work. So double qualified.
Okay. So
highly experienced people at the PhD, but then because it is the grassroots, the first level of care, people tend to overlook it because as a matter of design, at the primary care level, you are expected to refer cases to the secondary care. Okay. Cases you can manage.
So they feel, okay,
so that perception,
since I'm going to be referred anyway, I might as well go there.
People that refer patients. So it's likely they don't know enough. Now, that referral is not as a result of lack of ability, but as a result of design, policy, and protocol. There are certain things that are forbidden at the primary care level in terms of case management, that you must refer this to the secondary care. Not because the personnel is not there. At the primary health care, there are doctors who can do surgeries. But performing surgical operations, especially major ones, are forbidden in the primary care.
I won't lie, I was surprised when somebody had her baby in the primary healthcare center. I thought this was not allowed. But they said, no, it's quite fine. So, you people need to educate us so that we know what we can take to the primary healthcare center, what kind of problems we can carry there. You understand?
Okay, now let me just respond to what I was saying the other time, that the staff, the cadre of staff expected at the primary care level. We have the doctors, medical officers, we have the nursing officers, and a double qualified or single qualified. as the staff nurse or the staff nurse midwife. We're expecting the community health workers and community health extension workers.
Okay.
We're expecting the medical record officers or medical record technicians. We're expecting the pharmacists or pharmacy technicians.
Okay.
We're also expecting laboratory scientists or laboratory technicians.
You have lab scientists there
Lab
too?
scientists and laboratory technicians.
But the truth is we don't always see all these people there. Sometimes they are lacking, aren't they?
Well, I can't fault that because going further in this discussion, you discover that there are a lot of gaps in terms of personnel as far as the primary healthcare is concerned.
Tell us about some of those gaps.
Starting from the one we're discussing right now, which is in terms of personnel. However, it is not limited to the primary healthcare only.
Okay.
We have gaps in the secondary level. We have gaps at the tertiary level. I think nationally, we need to look at how we can improve, and recruit more health workers across board, and stop this issue of brain drain that is currently ongoing. You see a
That
lot of
is a
doctors,
big issue.
nurses running outside the country to UK, to US, for greener pasture. So the government needs to see what they can do on that to stop brain drain. That's one. Two, to also see what they can do in terms of increasing access to postgraduate studies. Increasing access, because a lot of people want to study medicine or want to study nursing, and they can't get access because there is a cap on what the university can take per time.
Okay.
So many of these, after 2-3 failed attempts, they just deviate and move to another career. So, but if the government has built a lot of capacity to absorb people, I have somebody very close to me who loves the nursing job, but could not get in just because of, we have a cap.
Okay.
Not because you didn't do well. The cap will determine the number of intake per time. And that will determine, for example, you have 70 people scoring above 70%. 70% is a good score, for God's sake.
It's a
but
good
because
score.
you have a cap already, you can't take
And
more
you
than
can't
25.
take all the 70.
So you have to rationalize. So you take 80% and you stop at the level of 75. But you have also disenfranchised someone who scored 70%. So the government needs to expand capacity so that many more people can have access to medical and paramedical courses, and they can fulfill their dreams. Then we cannot go scale up further. When they are true, you have vacancies, to bring them in. Currently, the doctor to patient ratio in Nigeria, is terrible. Because averagely,
some say as much as 1 to 3,000.
Exactly. And should be more than 600, 700 doctors. So that disparity is still there, and it's across board. Health workers are overwhelmed. We can see from this issue of COVID, we see how a lot of health workers, are overwhelmed. Some of them, along the line also had COVID,
Yes.
infection, and they had to isolate and things like that.
Okay, talking about COVID, let's say somebody is coming to the primary healthcare center. The person has fever. Now, this person, unknown to him, has contracted COVID-19. He steps into the primary healthcare center. Take us through the steps of how he's going to be treated and what's going to be done for him.
Okay, that's a good question. Any patient that comes into the facility today,
That's primary healthcare
primary
facility.
care facility today, at the entrance, you will be expected to first of all practice hand hygiene.
Okay.
Because it has been mandated by NCDC, and various regulatory bodies has also come to inspect to ensure our primary healthcare facilities have that at the entry point. So wash your hand, then after that, or sanitize as the case may be. You get entry into the facility. Now, at the facility, you'll be meeting the medical record officers who are properly using their PPEs, and from there, they take the documents, your name, your address, and take vital information about you, your biodata. Then from there, you proceed to...
Of course, the patient is wearing a mask.
Exactly, wearing at least minimum a cloth mask for all patients. While the health worker is expected to wear a surgical mask or other special types of masks. So from the medical record office or department or unit, you move straight to the OPD, outpatient department, that is being manned by the community health officer or community health extension officer. Don't forget, the medical record unit is being manned by medical record officer or medical record assistant. So at the outpatient department, where you have the community health officer or extension officer, your vital signs are being done.
All this time, the patient is being touched. They haven't discovered he has COVID.
Not yet.
So how are they keeping safe?
Now, during this period, as soon as you gain access to the facility, there is a physical distancing.
Okay.
The chairs have been arranged at the reception in such a way that there is a minimum 2-meter gap between one patient to the other while you are waiting for your turn, in assessing the next level of care. So that one is being done. Face mask is also there for all patients who are coming in. That was also part of it. Then the health workers who are touching now are wearing gloves, wearing face masks. They're also sanitizing and also keeping a distance.
But are you doing that right now?
Well, it's ongoing. But like you do say, this is something that we must keep on ensuring that it gets done. Because the tendency is there, to keep off. The tendency is there for you to relax. The tendency is there for you to say, okay, the COVID-19 cases nationally is reduced, the statistics is reducing, so I don't want to put on my face mask. For example, when I walk into a facility, I see health workers, I challenge them, hey, you are not putting on your face mask. Oh, what's happening? So that is there. It must continue.
Okay, so this patient, they've discovered he has a fever. Do they have the facility to check if he has COVID?
Okay, let me run quickly. At the outpatient department, the community health officer, they do your vital signs and things like that, then pass you straight to the doctor. Now, the doctor look at your vital signs and say, yes, there is a fever here. Maybe a fever and a cough, or a fever and a sore throat. So a doctor sitting there with high index of suspicion tells you, okay, you will undergo certain tests. Number one, you want to think broad as a doctor. That, well, this might be a COVID and this might not be a COVID. So right there and then, you are being sent to the laboratory, the facility laboratory, to undergo certain tests, like a full blood count, like a malaria parasite, and things like that.
And there's a lab?
There's a laboratory. Now, in some states, Lagos inclusive, COVID-19 sample collection has been decentralized to all flagship primary health centers. Okay, so in all the flagship primary health centers, you likely find a particular cubicle or section, not within the facility, but maybe within the compound or very close to the facility where COVID-19 sample collection can be taken. Can be taken. So while you are seeing the doctor separates. You go to the proper lab where further normal tests can be done. Then
such as malaria.
Exactly. There's another lab you will be referred to and directed to not far from the flagship facility where you have to undergo your COVID-19 sample collection. Okay.
So if somebody goes to a flagship primary healthcare center,
yes,
he's assured that once he walks out, he will know in a matter of hours or days whether he's positive for COVID-19, malaria, or any other thing.
For malaria and any other thing, yes. But COVID-19, not yet.
Not yet.
Why? NCDC has not approved any test kit, antibody test kit, COVID-19 test kit, for us to be able to do that. Assuming we have that done right now, any patient that walks into the facility can go out with his COVID-19 status as checked by a rapid test.
Because you see, that's the full decentralization there.
Exactly.
Are there plans to do this?
Well, I think there's an effort ongoing by the NCDC to quickly ratify some test kits so that we can decentralize all these test kits to all our facilities where a preliminary testing can be done. And if a patient is found to be COVID-19 positive based on antigen antibody detection, then a further referral can now be made to go and undergo a PCR, which is polymerase chain reaction, where we take the NASA specimen.
Okay, so he will have to do another test.
Another test.
Just to be
sure whether the COVID-19 is ongoing or a recovery.
Okay.
Yes, because once we do a rapid testing on a patient and is positive, it doesn't mean that the COVID-19 is ongoing.
It could be his antibodies talking.
His antibodies that you have recovered from COVID-19. You've had it, you recovered from it, but currently it's not ongoing. So we now send you for a PCR.
A more sensitive test.
Exactly, a PCR to now know the status of the antibodies we found in your blood sample.
Okay.
So we're expecting that full decentralization and that quick approval of a diagnostic, a rapid testing kit, where a patient that comes in can also do a COVID-19 testing and know his or her status right there and there.
All right, let's go on a break. We'll come back and continue this. Stay with us. We're going on a break. When we come back, we can get your questions. Welcome back. We're talking about the primary healthcare sector and how it features into the scheme of things in disease prevention. This is Health Matters on Channels Television. The number to call is 0808 054 2233. It's going to be showing on your screen in a minute. And you can tweet at CTV_Mary A if you have questions about the primary healthcare center, especially in relation to COVID-19. Now, so this patient is eventually going to be referred because he has to do a PCR test. And that means that he cannot be cared for. Well, let's not say cared for. He cannot be kept in the primary health care facility. All right.
Now, in some states where home-based care has taken off,
all right, yes,
there is a group of rapid response team per every local government, especially in some states who are having high incidence of COVID-19, Lagos inclusive, where we have a designated medical doctor at the primary care level, a designated medical doctor, a community health officer, a laboratory technician or scientist.
Let me quickly take Ishaku. We'll get back to that. Hello, Ishaku. Oh, Ishaku is not there anymore. Go on, technician.
Okay, yeah, level technician, designated set of people that will now follow such individuals up to
in their
his
homes.
or her home.
They will also be responsible for checking if the home is appropriate.
Such individual, exactly, inspect your home first of all, whether it's appropriate for home-based care. Once it's appropriate, then they give you all the thermometers. Remember, Lagos State launched that home-based care pack, where we contain a thermometer, a sanitizer for every positive patient. So they give you that pack. Now, after the first interaction with that team, the next interaction is going to be over the phone, where you call in and you give them your temperature readings on a daily basis.
Okay.
And you also tell
Let
them
me give
how
you the
you're feeling.
broader question. Before I do that, I'll take Charles. Hello, Charles.
Hello.
What's your question?
Yeah, my question that I don't really know about this health of disease you people talk about. Because my question there is that I don't really know anything about this disease you people are talking about, because number one, I only hear it by ear and heard it at people's mouths. And where I stay in prison, so in prison, it doesn't know anything like that. So when I came out, but I have to respect myself and follow the rule and the regulation that the government kept down, so that we should not be gathering together.
Let's see if we can handle that before we go to other things. This is the problem I think we have in this society. People don't believe this thing exists because lots of people are not coming out to show that they've had it. Neither do we see those who have it in the isolation centers. I'm not saying people should go in droves to the isolation centers, but at least let us see pictures of a few people who are willing to show themselves with the condition.
You have a point there, and I think the government, in a bid to reduce stigmatization of COVID-19, knowing our culture in Africa and in Nigeria, we also, in a way, lost some degree of trust from the community. However, there should be a balance, because there are certain things you put out there as far as content is concerned, from COVID-19 management to patients and things like that, that makes the community to actually believe in the message. Initially, everybody bought into COVID-19, that it is real.
But after a while,
there were a lot of restrictions were flaunted by people. Non-pharmacological interventions were trashed by some important people in the community that people did not expect. A lot of rallies, political rallies were going on.
How do you think we can fix that?
The government needs to come to the party. Re-engineer your risk communication team. Increase awareness. Give an update. Come up with pictures.
And perhaps obey your own rules?
Exactly. The rules you are setting.
Political rallies.
Be the first person. Elections have taken place in the last couple of weeks. We saw rallies. We saw people not putting on face masks. The same government that is asking people to stay at home, the same government that is telling Nigerians that there is a curfew. Now, elections are coming up very soon now in some other states. What are we going to be seeing? Are we going to see a mass of people that will not observe any form of face masking, social distancing, and things like that? So, what you are saying and your language must align as a government for people to trust you.
Okay.
And you must put your money where your mouth is.
All right. Now, let's talk about this issue. They say that it's the Ebola framework they are using for COVID-19.
That's right.
But let's take Chima first. Hello, Chima.
Hello,
Chima.
Yeah, good afternoon.
You sound very clear from Turkey. Good afternoon. What's your question?
Yeah, my question is this. Here in Turkey, we've seen a lot of victims. They're showing us on the TV, seeing a lot of things happening. We know that these people have COVID-19. They have the virus, the COVID-19, But in Nigeria, we come to see that it's all about scamming. It's scamming us within the indigenous there. We've not been seeing any news about anyone who has this very virus. They've not been showing us. They're only showing us in the news that some people have it. They only tell us some people have it. Yeah,
Chima, we'll handle that. I do, in fairness, I have seen some people come on air to talk about their experience after they recovered.
Exactly.
But perhaps it's not enough.
Not enough. Based on the awareness that we had initially created and based on the COVID-19 realities in other parts of the world. So I think the government needs to do more to bring more people on board, to be able to talk about the experience, and not hiding figures.
Okay, so quickly, the framework of Ebola and the framework of polio, that it's being used to tackle COVID. How so?
Now, the framework of Ebola.
You have to do that in 1 minute.
The framework of Ebola really, it was a framework that used the health workers, the structure of isolation that we have for tuberculosis disease in our infectious units.
Okay,
yes.
tuberculosis.
Yeah, exactly. So we already have a structure for that. So when Ebola came in 2014, it was that structure that the framework was expressed, because during that time we have the infectious disease hospital turned into an isolation center. 1, 2, we have disease surveillance officers in all the primary healthcare level who have been managing tuberculosis cases, who have been active surveillance for TB cases. So these are community health officers. So this same set of people were turned out as surveillance officers for Ebola when it came. Now, contact tracing was done, line listing of cases were done, contact tracing also was done. You map out the different community into wards, and because at the primary care level, the disease surveillance officer, the contact tracers are there, they're able to track people who have had contact with Ebola. The same thing we are doing and we have done, for COVID-19. So track people who have had contact with cases, and from there get their names, their address, send thermometers to them, follow up with their vital signs, and from there do a reporting back to the local government. So that is the structure for Ebola. That is the structure that is also working for COVID-19 at the primary healthcare level.
All right. I have to stop there. It's been wonderful. I could have you for 2 shows at a row. But thank you so much for coming. And thank you so much for being with us. Thank you, our callers. Destiny, you didn't get through, but we thank you. Charles, Chima, all the way from Turkey, Ishaku, and then Odun from Florida. Thank you so much for calling. Have a wonderful day, everybody. I am Mary Alale Yusuf.